So, welcome everybody to the 19th Journal Club for the European Journal of Cardiovascular Nursing. My name is Dr. Loreena Hill, and I work in Queen's University Belfast. And with me today is Dr. Angela Durante. Angela, would you like to introduce yourself?
Thanks, Dr. Hill, for moderating me today in this journal club. It is a double honor for me today to present this paper and to do it with you. I'm Dr. Angela Durante from Rome Tor Vergata in Italy, and my background is nursing, and currently I'm employed in this university as a research fellow in a postdoc position.
Lovely to meet you, Angela. So we're talking about the paper that you published this year. So what were your motives to undertake the study that has just been recently published?
So this paper is a secondary analysis of a previous study conducted in collaboration with the Department of Psychology of Milan Bicocca University that aimed to explore the level of self-care in Italian heart failure patient sample. Moreover, it was useful to determine the key role of caregiver confidence and how it affects the contribution to self-care. So based on these results, I focused the attention of my PhD on caregivers due to increasing the number of patients living with a chronic condition. And I'm going to take just a minute to express what we mean when we talk about informal caregivers and caregiver burden.
Yeah.
And formally, caregiver is the person unpaid that voluntarily take care of somebody who need it.
Okay.
Often it is a relative or a close friend, so somebody who normally say really close to the patient. The caregiver burden is a negative outcome of this process of caring.
Mm-hmm.
And we are not still able to determine which are the causes of this disease. But with this paper, we identified the determinants. So those red flags that can be considered as a sort of risk factor for burden development. But due to the multidimensional nature of burden, it is almost impossible to find the specific cause. So therefore, we focus more on those determinants which we can work on or reduce or literally remove them. So this assumption, we choose the caregiver burden inventory as the instrument for this study. That is divided in 5 dimensions.
Okay.
The time dependent that is related to the limitation experimented by the caregiver for the time that is dedicated in caring. The developmental burden that is for the fact that most caregivers missing personal goal or their own expectations. Physical burden, that is the distress and the somatization disorders that came from the fact that they are caring for somebody else. And finally, the social burden is related to the sense of uncomfortability with others when they are taking care, and the emotional one that is related to feelings of shame and anger with the patient.
Okay, and that's a validated tool, Angela, already in use in heart failure patients.
Yes, it was validated in heart failure patient just 1 year ago. So there was a previous study that was made for validating this in this kind of population.
Brilliant. And just looking at the paper and what you're mentioning there about the prevalence of heart failure, and a lot of these heart failure patients, as you know, are getting elderly as well. So do you want to make a comment on the type of caregivers that are actually recruited to your study? Because there was, it was a very interesting sample that you had and something that I wouldn't have anticipated.
Yeah, as predicted by sociologists some years ago, our sample already experiment and shows the trend reversal in the caregiving population. So namely, we still find spouses for a third of it, but most of the half of the sample is composed by adult children, in particular, they are daughters.
Okay.
So this phenomenon is particularly true in those countries with familistic welfare.
Right.
And the familistic welfare is quite common, especially in South European countries like Spain, Italy, Greece. Right. That means that the family is play the biggest role
Yeah.
in the overarching architecture of the welfare system. So
Okay.
they act as main provider of the care for those who are dependent individuals living at home with a illness or a chronic disease.
Mm-hmm.
So socially speaking, this is an aspect that we should not um, ignore due to the fact that, for example, our sample is living with their failure for more than 4 years. So if we consider that there is somebody who is taking care of them informally and is reducing the working time, or worse, getting out of the labor market, and it's developing burden symptoms, and simultaneously we take in account the continuous growing
Yeah.
the chronic comorbidities and the projection made by the World Health Organization,
Yeah.
it's a little bit worrying to me as an healthcare professional.
Yeah. So you mentioned there was a group of caregivers there that really had to leave their work to look after their loved one. Would that be correct in speaking?
Yeah, some of them are starting. So they start reducing the hours of work. Then some of them unfortunately drop out. In another study that we are conducting now, we reach the 20% of the sample that is losing the job for this reason. And they are adult children.
Okay. And was there, what sort of age range were they? Very young, or was there, and then what was the sort of mean age of your
Yeah,
son?
they are in adult age, so around 40.
Okay, okay, very interesting, very interesting. And one of the results which I looked at as well was in terms of the higher level of this physical burden, and you mentioned the validated tool you used, this caregiver burden inventory, and I presume one of the aspects of this was measuring of physical burden. Is that correct?
Yeah, we already knew from literature that burden used to be higher in female and older age caregiver.
Mm-hmm.
So in relation to the physical one, it was a quite expected result.
Yeah.
Regarding the number of the medication, for example, it can be explained by the fact that in literature, it normally it is related to lower self-care levels. So this means that maybe these give more duties and worries to caregivers who try to compensate more the
Okay.
fact that the caregiver has these low self-care level.
Yeah.
Moreover, taking less medication could be believed by the patient as, I'm less ill,
Yeah.
so less compliant and adherent to health lifestyle.
Yeah.
Also, the result about the mental quality of life is interesting, but we have to take into account that our sample is in near class 3 and 4. So this often means cognitive impairment and consequently a higher level of dependency. Moreover, in general, caregiving is a burdensome situation by definition and tend to make caregivers isolated and in an exclusive relation with the patient. So if the patient has a bad mental health quality of life, this leads the caregiver to a somatization of the situation that can be translated into physical burden too.
Yeah. So a number of very interesting points there in terms of if they take less patients take less medications, caregivers can have more of a burden as well. And one of the other points that I noticed in the results were if patients were also more educated, if they were better
Yeah,
educated, it led to an increased burden, which again is very interesting as well. Because it would be what the reverse of what I would expect. If they were less educated, there would be more of a burden, but actually was reverse. What is your interpretation of that education and self-care? What would be your interpretation of that result?
Yeah, I have to confess that it was an expected result also for us. So even if we consider that nowadays patients are much more informed and higher educated, so they can be also much more critical regarding the provider prescription.
Yeah.
And maybe this critical attitude could increase the caregiver burden.
Mm-hmm.
In fact, the significance of this result is relevant for time-dependent dimension burden, but it's much more stronger if
Mm-hmm.
we look at social and emotional dimensions. These last two dimensions are composed by items that regarding their relation with others and the sense of anger and shame about the patient. So it's plausible to think about that the critical attitude of the patient can stimulate or feed those kind of feelings.
Yeah, interesting. Very, very interesting results. So really, you brought out quite a number of interesting results in terms of the education of the patient, the physical burden of the patient, the medications that they're taking. So in summary, what is the implications of your findings to today's really heart failure clinical practice?
Regarding the implication for the clinical practice, I want to strongly underline that we don't want to get into mental health professional competencies or skill. So burden, once detected, must be treated by mental health professionals, absolutely. But as nurses, and personally also as a public health researcher, we should take in account and in consideration those kind of alerts. That here in this paper are described as determinants to prevent instead of treat. So start before.
Yes.
So for further research, we are trying to summarize all the knowledge that is already available about the topic of burden and caregiver burden to try to develop an home-based intervention to make caregivers feel better. Technology in this may surely can help, but we are still working on how to make it cost effectiveness and moreover easy access due to the fact that as we know, the population is not still of caregivers is not still so confident with technologies. Moreover, we have to say that considering the result of this study, the caregiver contribution to self-care in heart failure patient can improve the patient's outcomes. So, and seem to be not burdensome, that this is wonderful. So for caregivers and as health professional, we should consider to educate them to improve patient outcomes without, so be safely that we are not going to increase their burden.
Yeah, so quite a number of implications in terms of sort of preventing them from getting feeling under pressure and feeling burdened, and also putting in place that if they do what we can do to help, and also appreciating the fact that this has an impact on patient care. So where is this taking you? Where is this study now taking you? Have you started any additional pieces of work?
Yes, we already started an additional piece of work. For example, recently we have concluded there are the early results that are now ongoing about the Motivates study, that is a study that was made on caregivers and patients for improving self-care using motivational interviewing, and the results has been recently presented at a conference. So I hope that soon they will be published as a paper too. And for the moment, this the motivational interviewing is a counseling technique. So it's a way of communication, is a soft skill. And we should, as nurses, really use it as an instrument for better education.
Perfect. Sounds really interesting, and more to come, Angela, more to come. So thank you for that. This has been a very interesting journal club. Thank you for presenting your work so articulately. I would like to invite anybody who's listening in to ensure they check the European Journal of Cardiovascular Nursing's website and access and cite and read your article, because it does have clear implications for our heart failure practice. So thank you so much for talking to me today, and enjoy the rest of your afternoon.
Thank you, Dr. Hill.